Okay, thank you. I was saying, I'm currently working in a multidisciplinary team involving internists, nutritionists, psychiatrists, and bariatric surgeons for the evaluation of obese and morbid obese patients, most of them undergoing bariatric surgery, and in particular sleeve gastrectomy intervention. In the last 4 years, we evaluated about 270 obese patients with a mean BMI of 45 kilograms per meter squared, mean age 34. And in these patients, we usually perform an interview regarding alimentary habits and behavior, so we get information about history of weight gain, previous attempts to lose weight, maximum weight achieved, physical activity, and so on. Then we proceed to physical examination with anthropometric parameters and to a glycometabolic assessment with glycemia, insulinemia, OMA, glycosylated hemoglobin if needed, lipid assessment, liver function assessment with NAFL score, macronutrients assessment. We also perform bioimpedentiometry to evaluate fat mass percentage and an ultrasonographic evaluation of visceral fat area and markers of early vascular impairment, such as carotid intima media thickness and flow-mediated dilation of brachial artery. We also perform a cardiological assessment with ECG and echocardiography. As you can see, ours is a global and multidisciplinary approach, since obesity is known to be related to multiple comorbidities. The most important are impaired glucose control and cardiovascular damage. In our patients, we observed indeed that insulin resistance expressed by HOMA seems to be an important determinant of early vascular impairment with decreased FMD and increased IMT. An ectopic fat depot could play a key role in this impairment. In our population, we observed that pericardium fat is in particular associated with high left ventricular mass, left ventricular dysfunction, and NAFL score, so fatty liver disease, as an independent predictor of reduced FMD and increased IMT. Speaking of cardiovascular impairment, we also investigated the role of the so-called natriuretic handicap. That is, that the higher is the BMI, the lower is the brain natriuretic peptide plasmatic levels. Well, in our population, we observed that to lower BMP corresponds higher left ventricular mass, lower ejection fraction, lower flow-mediated dilation. And our ongoing study is now focused on the evaluation of BNP receptors expression on the adipocytes derived from our patients who underwent bariatric surgery, both effectors and clearance receptors, in order to better understand the pathophysiology of the handicap. After surgery, at 1-year follow-up, we observed a cardiovascular improvement, but in our population, this improvement seems not to be related to BMI, neither to OMA, nor to fat decrease. So we hypothesized a role of inflammation and adipokines. After all, we already observed that adipokine MCP4 favors subclinical atherosclerosis by influencing MIP1 beta and eotaxin 3, which are predictors of higher IMT. Well, after surgery, we observed a lowering in MCP4. This is the last one is a study performed in cooperation with the University of Buckingham, UK, Professor Trehan. So this is briefly our clinical and scientific activity, but I wish to point out that this work is nothing other than a teamwork born from interest and passion of few people and surely needs to be improved. In particular, we need to improve our nutritional and lifestyle intervention. This is what I expected to gain, what I actually gained from this summer school. And I'm very glad to be here with you, to have the opportunity to share experience and ideas, and most of all, the opportunity to improve my knowledge, my approach to these particular patients with a view to the best prevention and treatment of obesity. Thank you.